All right, let's dive in. Today we're tackling something that's been making waves in the medical world. How should we be giving those go-to antibiotics, olactones, to our sickest patients, the ones fighting sepsis?
Yeah, it's a debate that's been simmering for a while. Lots of strong opinions on both sides. But luckily, we've got some fresh evidence to help us out here.
For sure. You sent over a really cool package, a brand new RCT, the BLING-3 study just out in JAMA, plus a whole systematic review looking at tons of RCTs on this very topic. Oh, and a critical appraisal document, too, to break it all down. Let's get into it.
Before we jump in, how about we just level set? Beta-lactam antibiotics, those are like your penicillins, cephalosporins, carbapenems, the bread and butter for fighting bacterial infections. But the question's always been, what's the best way to give them, especially for patients in the ICU, sepsis, where every second counts?
Right, absolutely life or death stuff. Traditionally, it's been intermittent doses, but this continuous infusion idea, the constant drip, it's gaining traction. So be aligned there. This is what it was designed to tackle, right?
Head on. Beeline a third was a massive undertaking. I mean, over 7,000 patients. 104 ICUs, 7 countries. That's a ton of data, way more than any previous study on this. They looked at whether continuous infusion of these beta-lactams actually impacted 90-day mortality, compared to that standard intermittent dosing.
This is where that critical appraisal doc comes in handy. Highlights the strengths, weaknesses, all that.
Absolutely. One thing that really pops out is the sheer scale of Beeling a third, not some small single center thing. We're talking a truly global effort, which means the results, well, they could be more relevant to real-world situations.
Okay, big study, lots of patients. What they find? Continuous infusion, did it save lives?
This is where it gets a little, well, maybe unexpected. The main outcome, 90-day mortality, no statistically significant difference between the groups.
Wait, so all that work and no clear answer?
Hold on, it might seem a bit anticlimactic, but here's the thing about statistical analysis. Nuance. Remember confidence intervals, they play a big role here.
Remind me why those intervals are so important.
Think of a confidence interval as a range of possible effects. Just because a study doesn't hit statistical significance doesn't mean there's no effect. With Beeline 3, that confidence interval hints that continuous infusion could actually reduce mortality by a meaningful amount. We're talking potentially almost a 2 percentage point drop.
Whoa, hold up. A 2 percentage point reduction in mortality, that's huge. Why wasn't that statistically significant?
It comes down to how we define significance in statistics. The study had a certain power in mind, and it just missed the mark. But that doesn't mean we toss the findings out the window.
So even though statistically it wasn't significant, the interval tells us there's a decent chance continuous infusion is good.
You got it. Clinically, a 2-point drop, that could be saving one life for every 50 patients treated. Those are odds you can't ignore.
Okay, I'm seeing why this is generating buzz. But the appraisal doc, it had concerns about the study design, right?
Yeah. Beeline 3 was open label, no blinding. Clinicians, patients, they all knew what treatment was being given. Always a potential for bias there.
So could that have messed with the results? Like doctors paying more attention to the continuous infusion patients, subconsciously giving them better overall care?
It's a valid thought. But the primary outcome, 90-day mortality, it's pretty objective. Hard to imagine bias really swaying whether someone lives or dies 3 months later. Plus, the authors, they really tried to standardize care across both groups. Helps to minimize some of that potential bias.
Okay, so BLING-3, kind of mixed bag. Big study, interesting results, not quite statistically significant. But that confidence interval, it's hinting at something real. What do we do with that?
That's where the systematic review comes in handy. See the forest for the trees, right? Combining data from multiple RCTs gives us the bigger picture, maybe even reveals stuff that individual studies miss.
So zooming out, looking at the whole landscape, what's this review telling us?
All right. This review looked at 18 different RCTs, Billing 3 included, over 9,000 participants total. That's a mountain of data. And here's the thing, unlike Billing 3 on its own, this analysis, it found a statistically significant reduction in that 90-day mortality with prolonged beta-lactam infusion.
So each piece on its own, maybe not totally clear, but put them together and a pattern emerges.
Bingo. This review gives us more confidence. This isn't just some random blip. Prolonged infusion, it really could be saving lives.
Now this review, it didn't just use the typical statistical methods, Bayesian analysis, right? What is that and why does it matter?
Good catch. Bayesian analysis, it's a different way to think about probability. It doesn't just give a yes or no, does this effect exist? Instead, it gives a probability estimate, based on what we know.
So not just prolonged infusion is better, but a percentage chance it's actually true.
Precisely. In this case, they found a 99.1% probability that prolonged infusion is linked to better survival. Pretty convincing, huh?
Wow, 99.1%. That sounds like a slam dunk change practice right now, right?
Hmm. Well, it's definitely strong evidence. But, like with all medical research, gotta think about context, the nuances.
Okay, let's talk context then. What are the takeaways for clinicians, the ones on the front lines? Every sepsis patient now gets a continuous infusion of beta-lactams.
I wouldn't go that far. Remember, these studies, controlled environments, every patient's different. Can't just apply these results blindly to every case.
So how should clinicians use this research?
It's a tool, a powerful one, informs decision making. This evidence, especially the systematic review, the Bayesian analysis, it gives us more confidence. Prolonged infusion, it can be a valuable strategy, particularly when keeping those drug concentrations high. That's critical.
That critical appraisal document, it mentioned that too, right? Continuous infusion may be more beneficial in certain situations.
Right. For example, severe sepsis, unstable hemodynamics. Those patients might benefit the most from continuous infusion. Maintaining steady drug levels in those cases, it could be the difference maker.
But it's not one size fits all.
Absolutely not. Stable patients, less severe infections, the benefits of continuous infusion, they might not be as pronounced.
So it's all about that individual patient, their specific needs, the type of infection they're fighting.
Exactly. Weigh those potential benefits against the risks. Tailor treatment accordingly.
This research, it's a foundation.
Hmm.
But the clinician, they use their expertise, their judgment, best decision for each patient.
That's the art of medicine. Blending evidence with personalized care.
Speaking of personalized care, the systematic review, they pointed something else out that caught my eye. They saw a trend, faster clinical cure with prolonged infusion. But the evidence wasn't quite there to make a strong conclusion.
Interesting, right. Makes sense intuitively. Consistent drug levels, hit those bacteria harder, longer, could lead to quicker resolution of the infection.
Seems like an area ripe for more research. Maybe a future BLING 40 trial, focused specifically on that time to clinical cure as main outcome.
I'd love to see that. Would be huge to know if prolonged infusion not only helps survival but also speeds up recovery.
That's the beauty of science. Always more questions, more to discover.
Absolutely. This research, it's a good foundation, but not the end. It's an invitation. Keep exploring, keep asking, keep pushing the boundaries.
Sounds like this whole continuous versus intermittent infusion debate, it's not over yet.
Not even close. Not as simple either. That's what keeps it interesting.
But for our listener, they're probably making these very decisions every day. What's the takeaway? What should they be thinking about after all this research?
The big thing is, we've got more evidence than ever before. Backs up the potential benefits of prolonged beta-lactam infusion, sepsis especially. Not just an idea anymore. The data says it can make a difference. Real improvements for patients.
So not ditching the old ways completely, more like adding a new powerful tool to the kit.
That's it. More options. Tailoring treatment to the individual. This research, it helps clinicians make more informed choices.
And about those individuals, that appraisal document, it brought up something important. Local resources, expertise, that kind of thing.
Huge point. Doing continuous infusion right, it takes the right setup, the right training. Not as easy as just flipping a switch. Hospitals, healthcare systems, they gotta be ready. Support this change.
So it's not just the science then. Practical stuff matters too.
Absolutely. We gotta make sure clinicians have what they need, use this technique safely, effectively. Standardized protocols, proper monitoring, education, the whole 9 yards.
Lots to think about. Beyond just what the studies say.
Always is. That's why these conversations are so important. Digging into the details, thinking about what it means in the real world.
Well, I think we did a pretty good job unpacking all this. Explored the research, pros and cons, the practical side of things too.
Definitely gave our listener a lot to chew on for when they're making these calls in their own practice.
For sure. So to our listener, keep digging, stay curious, don't be afraid to question things. That's what moves medicine forward, Always learning.
Couldn't have said it better myself. And with that, I think we've reached the end of our deep dive. Until next time.